So it's been well established that elevated cholesterol and atherosclerosis can lead to poor cardiovascular outcomes such as myocardial infarction, stroke, and even death. And we know that the landscape of lipid management is continuously changing, and this is reflected in a lot of guideline updates and new lipid-lowering therapy approval for management of patients with hypercholesterolemia. And it can be challenging for practitioners to keep up with this ever-evolving management on top of other areas, both within and outside of cardiology. So the goal of this paper is to provide a succinct review of updates to help providers keep up to date and provide a starting place to dig more into literature. So my name is Elizabeth Wong. I'm a pharmacist, a clinical assistant professor at the University of Houston College of Pharmacy, and a cardiology clinical pharmacy specialist at the Michael E. DeBakey VA Medical Center. The title of this paper is Review of Recent Literature and Updates in Non-Statin Cholesterol Management, and this will appear in the September issue. So there are a lot of guideline changes that have come out within recent years and a lot of changes within therapeutic goals, especially LDL-C goals. So we focused on the LDL-C recommendation changes in the guideline, and there's a table within the paper that really nicely outlines these LDL-C goals. To give a brief background, back in 2002, there was a third report for the National Cholesterol Education Program, expert panel on the detection, evaluation, and treatment of high blood cholesterol, and they based their LDL-C goals on the number of coronary heart disease risk factors that patients had. And they were noticeably less stringent for secondary prevention LDL-C goals, with a goal of less than 100 milligrams per deciliter. Well, that has changed since 11 years later in 2013, the American College of Cardiology and American Heart Association guideline shifted to defining 4 statin benefit groups, which we go to in the paper, and changed what was deemed an adequate statin response. So in this guideline, it was equated to a percent of LDL-C reduction from baseline. So for example, for a secondary prevention patient who is less than 75 years old, an adequate response would be a 50% reduction of LDL-C from baseline or greater. 5 years later, in 2018, a new guideline came out from ACC/AHA, and they included newer lipid-lowering therapies such as ezetimibe and PCSK9 inhibitor monoclonal antibodies as options to add on to statins to help reduce ASCVD risk. In addition to that, there were 2 criteria that secondary prevention patients needed to meet to indicate they had adequate lipid lowering. So an LDL-C reduction of 50% or more from baseline, and the LDL-C needed to be 70 milligrams per deciliter or less. And then just 4 years later in 2022, because there were newer agents that had been approved for lipid-lowering therapy by the Food and Drug Administration, ACC put out an expert consensus decision pathway on the role of non-statin therapy. And this document included direction for use on bempedoic acid, as well as inclisiran, for example. They also adjusted the LDL-C threshold for secondary prevention patients that were classified as being at very high risk. So they changed it from adding additional therapy if the LDL-C was 70 milligrams per deciliter or higher to adding therapy if LDL-C was 55 milligrams per deciliter or higher. And just to add on to more guidance that had come out, in 2023, the ACC/AHA guideline for chronic coronary disease was published, and this included similar LDL-C recommendations to what came out just the year before, with the exception that it did not include that 55 milligram per deciliter threshold for LDL-C for our secondary prevention patients in the very high-risk category. Now, when we're talking about LDL-C and lowering of LDL-C, the question comes up with how low is too low? And it's a great question. We know that we probably need some LDL-C, but from the data that we currently have, LDL-C levels less than 30 milligrams per deciliter aren't associated with cancer or neurocognitive impairment, for example. And that is what we know at the time of this recording, but probably more to come out within the literature on that. So we talked about a lot of the guideline updates that have come out, but on top of that, there's been a lot of literature updates as well that has come out within recent years. There are 2 major landmark outcomes-based trials that came out looking at the cardiovascular outcomes of PCSK9 inhibitor monoclonal antibodies, the FOURIER and the ODYSSEY outcomes trials. Both of these trials found a reduction in the primary outcome with the use of evolocumab in the four-year trial and alirocumab in the Odyssey Outcomes trial, along with pretty significant LDL-C reduction. So in the four-year trial, there was an LDL-C reduction of 59% for those on evolocumab versus placebo, and a mean LDL-C of 30 milligrams per deciliter at 40 weeks. In the Odyssey Outcomes trial with alirocumab, LDL-C decreased to 66 milligrams per deciliter in the alirocumab group. That was compared to 103 milligrams per deciliter in the placebo group. So LDL-C reduction, in addition to cardiovascular benefit with these two medications, or this class of medications. For bempedoic acid, there are 4 different phase 3 trials looking at LDL-C reduction, and there's one cardiovascular outcomes trial called the CLEAR Outcomes trial that looked at cardiovascular outcomes with bempedoic acid. Ultimately, what they found is LDL-C reduction from these trials. It decreased LDL-C from 17.4% to 28.5% at 12 weeks. In addition to that, the CLEAR Outcomes trial evaluated patients unable or unwilling to take a statin, and a reduction in the primary outcome was found with bempedoic acid compared to placebo, with the difference being driven by non-fatal MI and coronary revascularization. So of note, the primary outcome included a composite of cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. And then for inclisiran, there are a few different trials out there, but the Orion 10 and the Orion 11 trials evaluated patients with ASCVD, and Orion 11 also evaluated patients with ASCVD risk equivalents, and they found a reduction of LDL-C when compared to placebo. So in Orion 10, the reduction at 510 days was 51.3%, with a between group difference of negative 52.3% when compared to placebo. And in Orion 11, the between group difference was negative 49.9%, comparing inclisiran to placebo. So where did that leave us in pharmacological management with so many new lipid-lowering therapy agents within our armamentarium? Really, first line and still the cornerstone of hypercholesterolemia management are statins. And of note, when a statin is started, it's important to check a lipid panel 4 to 12 weeks after to assess for efficacy and adherence. But where do we go after that? So for adults 40 to 75 years who fall within the primary prevention group, you'll get your 10-year ASCVD, calculate your 10-year ASCVD risk score, assess the patient's risk-enhancing factors, and identify what statin intensity to start the patient on. But if the patient's still not at goal after maximizing the statin, ezetimibe is reasonable to add on. And really, PCSK9 inhibitor monoclonal antibodies are typically not recommended for this patient population. For patients with LDL-C of 190 or greater, really first line is starting with a statin and maximizing that agent. And then second line is ezetimibe and or PCSK9 inhibitor monoclonal antibody. And then third line is bempedoic acid or inclisiran. And it's important to note, if you're starting inclisiran, that's going to be in place of a PCSK9 inhibitor monoclonal antibody, not in addition to. So it's substituting for that PCSK9 inhibitor. For patients with ASCVD, they should be started on a high-intensity statin or maximally tolerated. And ezetimibe can be added as a second agent when PCSK9 inhibitor monoclonal antibody can be started in place of or in addition to ezetimibe. And then if the patient is still not at goal, at that point you can consider bempedoic acid or inclisiran. Again, inclisiran in place of a PCSK9 inhibitor. When you're thinking about managing these patients, it's important to be aware of therapeutic inertia or the failure to intensify therapy despite a patient not meeting clinical goals. And de-escalation is also something to think about. And that's not something we talk about a lot, but a lot of it is going to come down. When do we pull off some of these agents? It's going to come down to clinical judgment, assessing the patient's pill burden, cost of medications, the patient's quality of life, and probably most importantly, the patient preferences and having that conversation with them. So that is kind of an overview of the article, but please take a look at the article for further details.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.